Tenakoto Kator. My name is Richard Edwards. I'm the co-head of Department of Public Health. Welcome, everyone. There's a lot of people I don't recognize. You're very welcome. Thank you for coming along today. So this is one of our series of public health seminars on an unusual time for us. And it's my great pleasure to welcome Professor Wael Al Delaimy, who's come away from California, San Diego. And so Wael is a friend of the department. He did his PhD in the department. He originally comes from Iraq, where he did his medical degree. And he came and did his PhD here in the department. So he's still got many friends in the department, and it's lovely to have him back visiting today. From here, he did his postdoc in Harvard. He spent some time with WHO, IARC, and then went on to the faculty of the University of California, San Diego in 2004. And he's currently a professor and division chief there of global health at the Department of Family and Preventive Medicine. And he's also the associate director of the University of California, San Diego Institute for Public Health. Wael's going to be talking to us about the big picture, the shift from public to global health. So I think that's going to be a really fascinating talk. So welcome again. Thanks for coming along. And also, sorry, I should say also welcome to the people who are calling in from outside. Great. Wael.
Thanks, Richard, and thanks everyone for coming. Kia ora. I am a naturalized New Zealand Kiwi and proud of it. Always make a note of this, whoever I go to, and including my kids who were born and now US teenagers. And every time New Zealand is mentioned, they look at me and begin rolling up their eyes. Oh, okay, here we go. You're going to say the sky is blue, the fields are green, people are nice, and so on. They're actually keen to come here. So I have the other Kiwi in our campus is UCSD. She's a staff person, a wonderful person. I managed to hire her to work with me. And so I told her, I'm going to New Zealand. Do you need anything? And the first thing she said, I would love some Vegemite. I said, okay, I still have time for integration as a full Kiwi because Vegemite and I don't get along very well. So, but I got for her some of that. So what I'm going to talk about in the time I have is a little bit of a snapshot of things that I have been doing and my kind of journey from public health to global health, and maybe kind of orient everyone about some of the differences and some of the priority areas. I have limited time, but I'll try and touch and go on some, so it's more of a breadth rather than depth, and we can have time for question and answer for anything that is needing more discussion. So the definition of public health is familiar to many, but this is one of the ones that are agreed upon, which is the science and practice of protecting and improving the health of community by prevention, education, disease control, sanitation, and monitoring. Or more simply, it's the collective personal health of a population, which is different from the health of an individual, which is the clinical-based health. So my work and my journey started with tobacco, and many people think tobacco now is a relic and it's kind of not as exciting, but it's still the #1 cause of morbidity and mortality worldwide. And these are some of the figures that showed how the consumption, this is from the US, consumption of cigarettes for male followed very much the lung cancer. Sorry, the lung cancer followed the consumption. So the consumption was ahead of that because of the lag period, and females kind of also following through. And this was very ecological, and it did, however, show an association that led to the further investigations that we have focused on tobacco. And so from my perspective, as an epidemiologist, we were interested in what else can we push and help understand for this association. We already know tobacco, active smoking is harmful. There was an area that is the passive smoking or secondhand smoke that is still a very contentious area that, a few years back, it still was being pushed back and forth. Well, it's not very clear that the harms are so great and so on. And the reason is because unlike active smoking, secondhand smoke is a multiple factor intensity. There's ventilation, there's how far. It's very difficult to capture through a questionnaire. So there was a lot of sources of error. And once you have sources of error, you don't have good associations and disease associations. Plus, the risk is lower than active smoking. So the active smoking may be 25-fold, odds ratio of 24 or more. It is more in the, 2 odds ratio or relative risks and less. So it's not easy to capture. So among the available methods, the biomarkers seemed as the promising area, and that was most of my work here was on this area. And we developed the method for hair nicotine. This is during my stay here between 96 and 2000. And the hair basically is cut and digested through NIH, and we run it through HPLC, and we get a signal of the nicotine after we properly wash it so that nothing from the outside, it's internally through the bloodstream and growing through the hair, and we analyze it and know this person is exposed more objectively rather than relying on reporting and so on. So that helped us understand some of the behaviors. So for example, in this study which we did with Julian over here and Alistair, was looking at the nicotine levels. If you can see here, the nicotine levels of children in the hair of children who there were no household smokers compared to nicotine level of hair of children who had people who smoked inside the house. And you can clearly see this is the median, right? And this is the median, and this is significantly higher. So this was proof that being in a household that people smoked will expose those children. But more importantly, we didn't know that, but we found that those very high levels of exposure among those who were in supposedly no one smokes in the home. Yet they were even higher than the children who were in this area. So that is an advantage of a biomarker. That's advancing the field. So when looking back at the questionnaire, and we had some good questionnaires, turned out all those had regular visitors who smoked inside the home. So managed to capture that question and then understand it. Without a biomarker, we would have thought, oh yeah, a visitor, once in a time comes and it's not important. However, it's shown it's very important. And actually the highest point, which was very intriguing, had 12 visitors a day smoking, which is a very popular house for some reason. But that kind of tells us biomarkers can help us understand. But furthermore, when we looked about those who smoke inside the house versus outside, there was no difference. And we were taken aback. What's going on? It can be. People who smoke outside must have their children's level lower. But the biomarker cannot lie. It's objective. So we thought it could be misreporting. Probably the parents are smoking inside or near the balcony and they're getting their kids exposed. Well, now we know there's third-hand smoking. And third-hand smoking is just in the past few years now has been documented that in a place, in a car, in a room, the carpets, the surface will keep on emitting these byproducts, including nicotine, including carcinogens, for years afterwards. So imagine if somebody just smoked outside and they came and took their child, their breath, their clothes, everything. So in a way, that is important that people should only don't smoke if they want to protect their children. So that was one of the things that, one of the papers from my PhD and one of the areas of interest for me on tobacco. We also did a study on bar and restaurant workers because in that time, bar workers or bars were exempt from having smoking bans. And their assumption is that no matter how much there is secondhand smoke, the exposure cannot be as high as somebody actively smoking. This is the first paper to show otherwise. It showed that among those non-smoking workers, bar and restaurant workers, their hair nicotine level, this is the median, was comparable to active smokers from the study. And these are light smokers, by the way, they're about 10 cigarettes. This study was very instrumental to change the policy here in New Zealand, where afterwards it was used to ban smoking. By that time I had left to Harvard, and I got an email from the Ministry of Health wanting to meet me and discuss the paper as they are considering banning smoking. And I said, sorry, I'm too far to come back, but you can use the paper. There was another paper or two, I think by George as well, that George Thurston, that was used. But this is how important it is that epidemiology and can advance policy. And you know, one study is probably as powerful as any. So when I went actually back to Boston, they were considering also passing a smoking ban in the city. And the usual thing happened, the tobacco industry funding, a lot of people go, testified, I'm going to lose business. My business is going to be lost if you're going to ban smoking, and so on and so forth, trying to persuade the council of the city not to pass the ban. However, I learned about that, and I asked our media people at the university to communicate the study. So that study was cited by the Boston Globe and saying the proponents of the smoking ban are getting help from afar. And they did an interview saying from New Zealand, it's shown that actually, you know, having smoking in the places exposed the workers to extreme levels of secondhand smoke, and it was used to pass the ordinance. And again, I was asked to testify as an expert witness for the city council. Now, that had ramification. Somebody from Kentucky heard about this study and the news, and she contacted me, and she said they are passing a ordinance to ban smoking in Kentucky, in Louisville, which is tobacco country. And basically, she needed help to support this. So, and she looked at this study and said, let's do something similar. So we collaborated and basically took hair samples from the bar workers where smoking was allowed, and their nicotine levels were so high compared to the workers in restaurants where smoking was not allowed. After 3 months of the passing of the ordinance, we took another hair sample from both, and we see the immediate decline, amazing decline. That study proved very helpful. After 1 year, the city council was considering lifting it because a lot of complaints, we're losing business. Again, we showed the evidence it is for the protection of the workers, and that ordinance continued until today. So these are some of the examples where tobacco control and my personal interest were all helping move policy and public health at that level. From that, I was working with a nurses' health study group, and they had access to toenails. 62,000 sample stored in a basement. And it was kind of interesting, me going through each and collecting a random sample. We had to choose a case control study and looked at toenails for the first time, actually showed it was a good marker also of secondhand smoke. And in this case, we showed that it can be associated with the higher levels of the nicotine in toenail. There was higher risk of coronary heart disease in the nurses' health study. And then the other areas that I got interested in is also in public health and diet, where, as you can see, you know, this is again in the U.S. The trends of overweight and obese going up, and extremely obese as well. And this is a problem related to diet, and including the quality and the quantity, the portion size, the type of energy condensed food, and the fast food that has been linked to these increased. The nutritional epidemiology has many challenges to prove these associations because they relied on poor measures. Food frequency questionnaires, dietary records, and even the biomarkers were not as well developed. So that to continue my work on tobacco, I wanted to move on into the nutritional area. And when I moved from Harvard to the WHO, I was in the diet and cancer unit. And there we had access to samples collected from many people. And we wanted to show which of these markers, carotenoids, the lutein, zeaxanthin, beta-cryptoxanthin, and lycopene represents best the vegetables or fruits as a marker of eating these products. So among those 3,000 people, we had information about the frequency of taking these as well as samples, blood samples, serum samples. So what was interesting here is you can see the correlations. These correlations are rather weak, 0.39, 0.38, 0.36. Now, this is a little bit higher, but in general in the 30s and 20s. So it wasn't explaining completely the intake of these. These are individual data. So each individual, the average of those people that were collected at an individual level in terms of the association. But when we looked at, and these are 24-hour recalls. So these ones are 24-hour recalls. So one time, what was your intake? And we took it as the exposure. When we looked at aggregates, according to region, so basically if we say everyone in this city who eats fruits and vegetables, and whether related to one of these, carotenoids, we found the associations were much, much higher, 0.84 and 0.68, 0.87 with each of these different markers. So what we learned from this was very important, that if you get one measure, which is a 24-hour recall, tell me what you ate in the last 24 hours. If we get it by individual basis, the relationship is not good. However, if we get it as an aggregate for everyone, then the variability kind of makes it more precise, because somebody ate a little, somebody more, and so on and so forth. But it was very much more accurate by region. And the regions here were in different European countries where, for example, lycopene was much more used in Italy because of the tomato, while beta-cryptoxanthin is more used in Scandinavia, which is related to carrots and others and so on. So these are areas that, I was invested for several years in public health. So then what made me think is, okay, I'm going to continue in this very exposure assessment area, refining it and finding better associations and improving public health, but I'm not seeing the impact as much as I would like as a public health person, as an epidemiologist. So I began to think of what is the bigger picture, what are the things that I can maybe impact on a big term, on a larger picture. And one of the things I began to observe is that more developed countries, these are like years 1600, 1900, 1950s, 2000s, and so on. In the more developed countries and the less developed countries, all of them suffered from infectious disease mortality. People were dying from infectious diseases. Then with better hygiene and beginning of vaccination, it became more morbidity. The infectious diseases were still there, but people were not dying of it, while in the less developed country, it continued in that same era. After we managed to get full vaccination, the infectious disease was kept at bay, but then we had the mortality from non-communicable diseases, heart disease, cancer, and respiratory, and so on, while it was still infectious disease mortality in the less developed countries. Now we are in the NCD morbidity. So people are living longer because of treatments. And only now in these less developed countries, we are managing to, let people live longer with infectious diseases. And the future is going to be in mental health, zoonotic pandemics, and global warming. This is how I saw the projection of public health. This meant global health, because these issues are really encompassing a lot of the same trends. Why should we let those people in these less developed countries suffer and go through the same path when we can help them jump and do a leap into the things we learned in prevention of non-chemical diseases, for example? So that led me to global health. But global health is a relatively new discipline, probably 20 years, maximum 30 years. It was called previously international health. International health is different from global health. You rarely find international health now because it usually meant governments from more developed countries helping governments from less developed countries. So there was this patronizing kind of up or down connotation or expression. Global health, on the other hand, is not. And really what I believe galvanized global health is the HIV epidemic. And this meant that, even though this is the kind of spread of HIV, even though it's concentrated in Africa, it meant it is affecting the whole world. And unless we keep it at bay here, everyone is going to suffer. And it is also causing total economic and political disruption, a lot of deaths that is going to have ripple effect in the rest of the world. So that helped move global health, and especially the US got interested and got funding into this area. Of course, malaria was always there, and now it is becoming even a more global health risk because of climate. And these zoonotic diseases and pandemics, we all heard about this. The SARS, 2002 in China, the swine H1N1 flu in 2009 began in US, the MERS coronavirus in Saudi Arabia, 2012, and more recently Ebola, sorry for the misspelling, Ebola in 2014, West Africa. So all these meant that no country is immune from a problem happening in another country. That is where global health become, the shift, what I talk about, and why public health professionals should all think the same way. So global health is defined as the health of populations in a global context that transcends the perspectives and concerns of individual nations. It tackles disease and prevention from a global perspective without being confined to the national or regional boundaries, which is what public health is. Public health is county public health, city public health, national public health. It is very much localized to a country. Global health is not. And it came with a new ethos and ethics, is that it tackles the most important health problems facing mankind in both poor and rich countries. So it's no longer about what is relevant to us as more developed. It's about everyone. And there's this kind of ethical concept of health equity, that health is a human right. This is really even a more progressive and advanced understanding of what public health is. The other thing is that it brought a very multidisciplinary, interdisciplinary concept to public health, even more than what we know. So social science, political science, anthropology, every aspect was as important as people who are trained in public health, and that made it even more unique. This has grown since I have got this data. It's about 136 universities worldwide has global health program, including 104 of them in the US. So this become a trend in the last 10 years. Now, with that, and with the reason why infectious diseases made global health, I want to go back to the shift that I mentioned, which is the non-chemical diseases. This is the future of everyone in the world, including the less developed countries. And it's very clear from this figure, well, just focus on the males, but they're similar. Males and females are almost comparable. But Africa is the only continent that has the yellow, which is communicable diseases, more than the red, which is non-communicable disease. Every other, this is the Americas, the Eastern Mediterranean, Europe, Southeast Asia, and the Pacific, all of it, the red is more than the yellow. That means non-communicable diseases is more important as a cause of death in these countries. And the same for females, you can see very comparable. The other thing is that there is the transmission of these risk behaviors that unfortunately started here and they are moving to the less developed countries, whether it's fast food, physical inactivity, tobacco, and so on and so forth. And so this map shows cardiovascular and diabetes death rates, and you can see the dark blue is the less developed countries, as it's being controlled in the more developed countries in Europe and North America and so on. So this is a picture I found, which I thought was kind of very telling. It's somebody who's drinking, has food, smoking, watching TV, couch potato, and that encompasses everything that is the major problem for public health. So as such, we expect that the epidemic of non-communicable diseases is appearing already in the less developed countries. So 63% of all deaths are from non-communicable diseases. Cancer alone is responsible for 7 million and reaching to 10 million deaths. But the other thing is that 70% of those are going to be in the developing countries. And these are some of the projections. You can, in the future of diseases, you can see everything is going down except road traffic accident will continue to increase, and cancers, ischemic heart disease, and stroke, which are non-communicable diseases. Everything is going down, including HIV and TB and acute respiratory illnesses. The other thing which grabs the attention of policymakers is the cost. So the cost, this is from World Economic Forum, the cost of $47 trillion output loss over the next 2 decades, which is 75% of global GDP, just from chronic diseases, non-communicable. And it is enough money to eradicate the $2 a day poverty among the 2.5 billion people in that state. In the US alone, just diabetes care cost was 92 billion 2002 and reached 147 billion, and it's increasing. So with that background, I want to shift with what are the 2 areas that we are interested in my division and personally I'm interested in, and then if we have time, cover a few other areas that I have been involved. So the global climate is something that is become very important, as we all know. It wasn't very much related to health. It was focused on, the glaciers, the snow peaks, and the wildlife ecosystem. But more recently, it is shifted towards the human health, which is really important to get the attention. But it manifests in many ways. So this is a study we published with one of our students from Japan, where Japan suffers from these desert dust storms that happen frequently, coming from the Taklamakan Desert in China. And if you can look, this is from satellite, the desert storm from satellite, and it travels that way and covers most of parts of Japan for days at a time. And it travels pretty fast around the globe in 13 days. So Japan has this light detection and ranging monitors so that they would measure mineral dust, which is differentiated from other pollutants, and compared to hospitalization of children with asthma in one city in Toyama, Japan. So we found the odds ratio that the heavy dust event for hospitalization was 1.88, and even after adjusting for other factors, it was still significant at 1.71. So that is a global issue. Dust from one country is affecting the health of people in another country. That is why global health can tackle that. Public health per se is going to deal with only Japan as the problem. We know the causes of global warming, and these are the typical things about the greenhouse effect, the ozone hole, and the deforestation, and the glaciers, and so on. This is a prediction of by 2070 where flooding will happen, that more than 150 million people will be affected. This is a huge public health problem, 150 million people across the world, and especially in Southeast Asia, low-lying areas. So we need to prepare and think about it. What is this going to have in terms of public health implication? This is a this was a lake in China, in Yunnan province, and it's interesting. This fish got trapped into this muddy, but it's kind of very telling, really, by itself. One of the factors that are related to the global warming is the biomass fuel, and this is something that probably not as much here, but in the less developed countries, there are 2.7 billion people who use it for cooking as a source of energy, but it is also a source of indoor and outdoor pollution. There are estimated 2 million deaths annually from indoor pollution, 50% of the total disease from indoor pollution in poor countries, and the contaminants are dependent on the type of the fuel that is used and what it has. It also is responsible for global warming because we have flooding, we have spread of disease and heat waves that are indirectly related to biomass fuel. So you have biomass fuel, you create global warming, and global warming causes all that. It also leads to deforestation and ecological and climate impact. The area that we have interest is what's called the short-lived climate pollutants, which not a lot of people concentrate on. But these are agents that have relatively short half-time, a few days to a decade. CO2 has much longer half-life, so it's very difficult to move the curve for CO2 compared to this one. I think it's about 100 years. So black carbon has a half-life of weeks, methane 12 years, ozone weeks, and the hydrofluorocarbons 15 years, and they are responsible for 40 to 50% of the CO2. So if we do an intervention today, we can have an impact by 12 to 15 years, compared for CO2 in general or other sources that it probably is going to take 100 years before we really show an impact. So the project that drew me into this area is ran by colleague and well-known climate scientist Ramanathan, and he has this project in India, and this is that people there use indoor cooking, and this is a picture from the villages in rural India. And the idea is, their work was, how is this going to impact climate change? So if you can see, this is all the smoke from villages and from satellite data. And they have published in Nature and other high-ranking journals of how black carbon can lead to melting of glaciers, and that this disruption can lead to climate change and global warming. So I was invited to look at what are the potential health impacts in that, and we're doing a study in India. The first part is we want to see how the impact of a improved cook stove, which does not generate as much smoke, has impact on health. So the first step, this is still preliminary data, we want to compare PM10, which is particulate matter, size 10 and 2.5 and 1, and carbon monoxide within houses with traditional cook stove, which is the picture you just saw, and these improved cook stove, which does not generate as much. And we measured it at 24-hour and also during cooking time. So the 24-hour, there wasn't a lot of difference. They average up. But during cooking time, clearly those who use traditional cook stoves have higher levels than those who use the improved cook stoves. The carbon monoxide was much more clearly declined in those who use the 24-hour compared to the traditional. However, it also showed us that the improved cook stove doesn't completely extinguish the exposure, because most people were still using the traditional with the improved cook stove. And that is a major dilemma for a lot of people who use these. There are hundreds of types of cook stoves, and people who think they give the cook stove to the villager that's it. That doesn't happen. They don't use it. So this is needing, we're looking further on why are they not using it. Now, mind you, this is a very improved cook stove that has light, that has a cell phone charging, and it has heating. So all of this still did not make people use it completely to the degree that the average would be much lower. And some of the reasons is that they say the food doesn't taste as good, or it doesn't cook as fast. So see, these are things that one has to take in consideration. We don't just apply things and think it'll work. We have to think more about it. So if we go to the biomass fuel, which generates short-lived climate pollutants as well as CO2, it has direct health impact: cardiovascular, respiratory, inflammation, oxidative stress, and indoor pollution. It also leads to climate change, which leads to all of these: flooding, environmental refugees, food security, infectious agents, heat waves, extreme weather, water quality, increase in pollens, and economic impact. And all these have health impact. So climate change is really a health problem, public health problem. Until recently, no one really paid attention to this as much as it should. Now it's picking up. So this is a model I put where it shows the circular relationship between biomass, short-lived climate pollutants leading to climate change, and then affecting agriculture, leading to poverty. So no source of energy other than biomass. They go get, again, the biomass, and goes into circle, and all of them have an impact on health. So shifting a little bit in terms of where this has us, we are writing a policy brief on climate change and health. I lead the International Joint Policy Committee of the Societies of Epidemiology, and this is a 21 epidemiology society, all represented in this consortium. And our aim is to generate, report, and apply epidemiological methods to the formulation, implementation, and evaluation of evidence for use in informing health policy. And so this is an effort we're doing as volunteers. It's driven as a nonprofit, but these are some of the things we try and do. The other area I want to bring your attention to is mental health. So in 2010, the aggregate burden of years lived with disability resulting from behavioral mental health was 22.7%, number one from all other conditions, musculoskeletal, other non-communicable. This is in terms of disability, okay? So this is a major problem, but definitely not something that is grabbing the attention of public health and global health researchers. And among those affected the most are refugees, as an area that I have a specific interest in. Refugees have reached a record this in 2015. This is the latest from the United Nations High Commission for Refugee Trends. 65 million refugees, and 40 of them are internally displaced, and 21 million are externally displaced. There are about 34,000 new refugee per day, and 12 So that's the 12 million in 2015 due to conflict. These two countries, Lebanon and Jordan, are the two highest number, has the two highest number of refugees per capita in the world. They are the smallest, some of the poorest countries, but they are getting the highest burden to any other. And 86% of refugees are hosted by the less developed countries. So just to put that in contrast with European countries, the US, and other countries where they take, 20,000, 30,000, this is a fraction of the real burden of refugee. And 51% of them are less than 18 years old. So that's also the challenge. In this paper by Porter and Haslam, I liked how they kind of compiled the suffering of refugees. They have psychological disturbances because of trauma. They have diverse stressors that accumulate over the pre-flight, flight, exile, resettlement. Post-migration stress face other than the war after the trauma, which is marginalization, socioeconomic disadvantage, acculturation difficulties, loss of social support. So the refugee experiences are characterized by multiple events occurring in multiple contexts that persist over time. This is very important, that persist over time. The refugee, when they are resettled, their problems are not ended and their trauma just do not disappear. And that's one of the reasons I got drawn into this, because our local refugee community were coming to me and saying, we're having problems. We're having mental health problems, suicide, and other violence issues related to traumatized people who no one is dealing with. This picture really exemplifies what refugees are. And this was an award-winning picture. This is in a refugee camp near Damascus, Syria. And you can see the background. Those are Palestinian refugees. So they were basically deported and displaced from their homeland in Palestine after 1967 war. And they were to return back. They were not allowed. So they were set up as refugee camps and in many years in Syria. And then when the Syrian war happened, they were bombed and located. They were not allowed to go out, no medicine, nothing to come, because some of the violent, rebellious groups were hiding there and they were bombed by the government planes. And this is a picture caught by a photographer at the time when they allowed UN to give some supplies, food and medicine, and people were just going out to get that. So it's a very captivating picture that shows how they have been twice refugees and displaced. So we formed a group, the Global Mental Health Initiative in the Middle East, and led by me and co-led by James Griffith, who is the chair of psychiatry at George Washington. And we had we have two psychologists from University of San Diego. They're family therapists. And from Harvard, we have a child psychiatrist, and we have a family medicine doctor. Our group is really a volunteer group to try and make a difference to the suffering of people in that region. So we focused on Jordan, and that's my main kind of area of work or country of work. So we held a conference last year. We brought all the stakeholders. This is the United Nations Relief Work Agency that deals with Palestinian refugees. This is the Ministry of Health representative. This is WHO representative. And this is the International Medical Corps representative, which is the main entity that deals with mental health among refugees. We brought them together and said, how can we help? We want to help. What are the needs? And we came out with the main thing is that they need more training to deal with mental health, because there isn't enough and the problem is much bigger than what they can handle. I had the chance to go and meet with the Minister of Health, and I asked him to write what they needed, and so we can see what we can do. So he gave me a laundry list of things, from establishing mental health units in general wards, training primary healthcare providers on mental health detection, an evaluation team for mental health, developing educational material to overcome stigma, and carry out EPI surveys for monitoring, and use successful program models. Well, we were able to fulfill within a year this one. So I'm going tomorrow, actually, traveling there, where we're going to implement a diploma in mental health, the first of its kind, where we're going to take primary care providers, 25 of them, and train them on primary care detection and treatment of mild common, we specifically focused on 4 illnesses because it's too much to try and put everything. These are the main problems in the population that go undetected: depression, anxiety, PTSD, and psychosomatic. And it's a 2-week training, face-to-face, and then online. And they will get a certificate and be recognized as leaders in mental health in their clinics. We couldn't have done it without the support of the minister, who was a very open, progressive-minded person. Otherwise, the politics and the bureaucracy would have prevented that. So I think I'm running out of time, so I don't want to go into more. I just want to say that we did look at trauma and mental health in the refugee population in San Diego. So we had a Somali community. We recruited 200 mothers and their child, and took information about the trauma of the mother, expecting we will find that mental problems will also be among the children. We did not find any association between the mother's trauma or even torture experience with any of these adjustment factors in their children: peer victimization, depressive symptoms, and perceived racism. So we were puzzled what's going on. However, when we did mediation analysis, we found actually if the mother was still suffering from mental illness as a result of torture, not just any traumatic event, as a result of torture, and torture here is extreme trauma, deprived of food, being jailed or seeing somebody or killed in front of them, and so on. These are termed torture. If they had anxiety and depression, then their children were not doing well. So then this is almost like transmission of trauma through the mother's mental capability. And it wasn't directly related, but it's only modified by those who suffer. I'm going to skip this because we don't have time, but I wanted just to make the comment here. This is the border between San Diego and Tijuana in Mexico. And although there's this artificial border, this is a basin that is shared between the two countries. So what happens here affects here. So these artificial borders are meaningless. That's why it's global health that can deal with it. Public health would say, oh, we'll deal with our side, you deal with your side. These are some of the students. We did the survey there. I'm just going to move very fast and finalize. So in terms of the picture, my work in public health was mostly with other fellow epidemiologists. Now with global health, it's with every other discipline that people can think of. This is an urban planner. This is a political scientist. This is a computer IT big data expert. This is an ocean physiologist, physicist. This is a health policy. Ramanathan, of course, is very famous. He's a physical and climate scientist, and so on and so forth. This is how global health looks. And if we look at this model of exposure leading to disease, leading to death, and we would focus as public health folks on exposure at the population level, it's really now encompassing all these disciplines, and it's not only public health. So going to the final thing is that when I was continuing my training, this is the area that was in research in public health. It's mostly disease-specific, organ-specific, or exposure-specific. This is the fields. And I had the opportunity when I was at Harvard to go into this molecular, precision medicine, molecular and genetics, and so on. I just felt I'm going even deeper, not to undermine or saying this is not important. Absolutely not. It's just my own personal view. I'm going deeper into the mechanisms, while my work really felt where I want to, have an impact more at the global level, chronic diseases, climate impact, and zoonotic pandemics. So in conclusion, I think, the shift is happening. It has moved to global health. I think public health professionals are not moving as fast and trying to encompassing the big picture, because there is a much need in this area to address these big problems of the future. Thank you.
Okay, thanks, Wael. So we've got 10 minutes or so for questions. So I want to kick off.
Hi, thank you for those case studies. It's actually really good to see the different examples and how it works, science and the policy, how it works through. What I got from it, though, is quite often it's about the right time coming up. So whether it's the New Zealand Ministry of Health, whether it's someone in Kentucky, whether it's the Jordanian, Minister of Health, often they are open and willing, and that's why the time is right for your research to be utilised. Is that the case, or are there things that you've done to get your research out there? That's the first part of the question. And secondly, what is the plan, if any, with this joint committee that you now have to push that towards government officials, towards bureaucrats to actually pick it up?
Yeah.
Thank you.
So for your first part of the question, it wasn't a coincidence. It was a lot of back-end effort to establish, in the case of Jordan, it was years of going and building trust. Just like you do with indigenous communities, these are people, even though I have the same culture, still you have to build a trust, and they trust that you are really wanting to help. It's not about money, it's not about personal gain. Once you have that trust, the doors are open, and that's everywhere. And so being of somebody with background and training in the US, there's a little bit more trust, and I have a little bit more leverage for that, but it didn't happen by coincidence. It's a lot of effort, and none of it is compensated. It's done out of my time, almost like volunteer, because I am really dedicated to that. And the people with me have shared the same thing. There are many other people who would be interested, but they are either too busy, they want to put their name but not put the effort, or they said, my time is precious. If you have funding to compensate me, I will be happy to. And we don't have funding. We're looking for funding. So for that aspect, as for the smoking bans and all that, it also came because of public health advocacy, because I make sure that my research is covered by the media. Actually, on the study here in New Zealand, we had with us Tricia Fraser, who was with ASH, Action on Smoking Health, as a co-author, because she did the data collection. We didn't have funding. She helped with that. So she made sure everyone read that paper. And so policymakers were fully aware of that. So that's very important. Your second question is about the International Joint Policy Committee. And I gave a talk about this at the conference in Sydney where I was, and epidemiologists are shy about policy. And they say, well, we don't have the expertise. And my view is that you don't need expertise. Your role is to start the ball rolling by getting interest. If somebody, policymaker, picks up on that topic, most of your work is done. They will take it on. You can help with evaluation, supporting evidence. But we're trying to do that through policy briefs, through the committee we are in.
Can I ask a question?
Yeah.
What about teaching? What about curricula on global public health? And are you doing anything with that? So I know in one or two places they've tried to introduce global public health into medical student curricula. So is that part of your work or others in the global public health movement?
Well, we have a PhD in public health that has 3 tracks. One is epidemiology, one is health behavior, and one is global health. So we have people who graduate with a PhD in global health. There is now a major that is undergraduates in global health, It's more so on anthropology, and it's kind of a little bit not quantitative, it's qualitative. But there are now these programs appearing in this area.
One here and one at the back.
Thank you for your lecture. It's been really interesting. It sounds like a lot of... Oh, you can't? Oh, sorry. Sounds like a lot of the work you do takes a long time to, come to fruition and to put into policies and things like that. Out of all the work that you've done so far, what's been the most challenging? What's been your most difficult project?
Well, I think from what I explained, the most difficult to get funding for is the mental health work, because that, when you say mental illness, immediately it's psychiatry. So people think, this is mental illness, this is area. And psychiatrists in the US at least are focused on mechanisms. So funding is about the biological mechanisms, the biopsychosocial aspects, imaging, brain imaging and all that as an explanation of disease. No one is looking at the picture that we're looking at in terms of prevention, early detection in the population. So we have been struggling to get funding. Big foundations like Gates Foundation and others are not interested in this area as well, even though this is the future. This is the problem of the future. So it's always the case that ideas, are ahead of the funding. So we're always continuing to try and look for funding.
I'd just like to say thank you so much for all this work that you're doing. It's so heartwarming for us to know that somebody's out there caring and doing the work, the practical work that's needed. And
thank you.
I don't have a question because I'm just amazed by the work that you've done. Kia ora rā.
Thank you.
Thank you for that wonderful overview. I work in a field where people are now frequently using the term pathogen pollution, with the major vector being, of course, 747 in the more recent versions. Do you have any comment or perspective to add on that?
Can you explain what pathogen pollution, because that's a new term for me.
Okay. The way that common pathogens are being spread around the planet by rapid air travel in particular.
Right. So there is that work that some of the pathogens are, attaching itself to particles roaming the world from Asia, from the desert, from everywhere. There is a lot of studies about this and some explanation that it's these pathogens that are causing the respiratory problems. It's still work in progress, but there are people who are working at the particulate level, analyzing it. And there's also some work about the oceans, droplets, and carrying with it the pathogens. And that's something, again, it's still in the physical science realm. It hasn't passed to the public health because the connection is not easy to connect, that this is coming from this. So that's my limited understanding of this topic. Yeah.
I think probably in addition to that is the fact that a lot of people are infected with pathogens who may not be showing symptoms. Yeah. And that the increased tourism and global international travel is adding to the way that these can spread and establish.
Absolutely, yeah.
Okay, I have one last question here. Oh.
Yeah. Hi. Thanks for your talk. I'm just interested in if you have a view on the use of public health data to support the development of genomics and developing personalized healthcare.
I have limited knowledge in that area. I think one of the areas that one of our colleagues is working on is collecting big, massive data and of genetics connected to a population demographics and other characteristics, and coming up with, some analysis showing where is the high risk genes and phenotypes and so on. In less developed countries, of course, the data does not exist, so it's not possible. But at least this is happening within molecular epidemiology and statistics.
Where is that happening?
In our department, there is somebody who's doing that work.
Okay, great. Because I understood that sort of confidentiality around public health data sets was a barrier to that work. But
it is, but this is de-identified and he has access. He has collected data. He's uniquely doing that.
okay, great. Thank you.
Strong hint that I missed the question.
No. Just look at class out. We have to go back.
Oh, right, and that's what the hint was. Okay, so thank you very much again, Wael, for sharing your journey with us and bringing to us so many sort of public health truths and priorities, and particularly about how public health crosses borders. I think is really important. The establishing of trust with populations, with working with populations, the collective nature of public health, and the importance of engaging with policy, which I think is something that we're fairly used to. But that idea of the sort of epidemiologist standing back, I think is fairly anathema to some of us. We need to get stuck in there and as you say, stimulate debate, start things off, and I think you've illustrated that very well, although I think you go a lot further than that as well, which is great. But if we just thank Professor Al Delaimy once more.